This is a discussion of clinical supervision, the current status. I'm Carol Fellender. I'm an adjunct professor at Pepperdine University and the co-author of 5 books on clinical supervision and miscellaneous articles. This is a presentation for the Hong Kong Association of Doctors of Clinical Psychology.
And I'm Rod Goodyear, and like Carol, I've got some books out, and I'm delighted to be part of this. I appreciate Carol having invited me aboard. I think in organizing this, let me begin with a few orienting statements, and then much of this will be about competency-based supervision, which is really Carol's turf, very much so. She owns it. Supervision is something that therapists credit as the most important source of their learning, their competence. And virtually all therapists eventually are going to supervise. And the problem has been that primarily people have learned to supervise by having watched their previous supervisors, or just assuming that being an expert therapist is going to make them a good supervisor. And the analogy that I've often used is having a coach, that just because you've been a great athlete doesn't make you a good coach, that those are overlapping but separate skills. And so both Carol and I have written and talked extensively about the importance of supervisors attaining competence through systematic training. And the cost of not doing so is really pretty high, as illustrated by work that Mike Ellis has done with respect to the extent to which supervisors are offering either inadequate or even harmful supervision. So for this limited presentation, we're going to focus primarily on 2 things. One is very briefly on the evolution of supervision models, particularly from an apprentice approach to one that focuses on competence, and then an overview of the competence perspective. And that's really, like I said, Carol's turf, and she'll provide an overview. And then we're going to conclude with addressing several additional questions that have been posed to us. And so the apprentice model of training is one that, as best we can tell, developed with Freud and his followers, that some would credit Freud as having been the original supervisor of psychotherapy. And he was very much the master and expected people to become like him and following his work. So that's really, as best we can tell, the origins of the master-apprentice model. And the assumption has been that people learn by participating with the master, sitting in sessions with that person, getting feedback, and so on. And it does have a couple of advantages. One is it offers excellent client protection, which is really the foremost obligation of a supervisor, protect clients. And it also does give direct observation of supervisee performance, which really is become the standard practice, be able to observe your supervisee and be able to provide feedback based on that. On the other hand, some of its drawbacks include not being attentive to supervisee's developmental needs, not allowing the supervisee autonomy to really try out things on their own and explore what they do well or don't. It risks idiosyncratic training that has holes in it compared to what you're learning is very specific often to what that supervisor is offering, as opposed to learning broad competencies that really cover a spectrum. And it also works from the really unexamined assumption that clinical knowledge and skills from psychotherapy models directly translate to supervision practice. I will say that there's one variant on the apprentice model that overcomes some of these problems, and that is co-therapy with the supervisee in limited circumstances. This is something that Kellen Mueller wrote about decades ago. Hector Fernandez-Alvarez has written about it more recently. And others have, and usually when this is offered, it's embedded in other forms of supervision, and it's very specific and focused, as opposed to, so it's an adjunctive approach as opposed to the supervision. And with this, so Carol, you've also got a slide coming up here about medical models of training, so maybe you could hand that to you.
Okay, thank you. Yes, medical models could and may provide exposure to evidence-based practices for psychotherapy, but it's generally accepted that that is insufficient to promote self-efficacy because it's reliant on the precision of clinical techniques, and it fails to adequately address the need to facilitate those therapeutic processes which are internalized over time by the supervisee through their clinical experience and practice. So psychotherapy takes place over time. Its efficacy relies so heavily on the clinician's personal understanding of interpersonal processes. And deleting that experience or not allowing the supervisee to have direct hands-on experience independently and to learn and grow through that supervised experience is a major issue. The APA guidelines for clinical supervision that Dr. Goodyear and I were both on the committee for assert the need for psychologists to better emulate efforts and practice what we preach in supervision to ensure that supervisees reach competence at the point of independent practice. So to move away from the medical model, we need to establish a climate of reflective practice that's internalized by the supervisee, and it occurs through supervisor modeling, through perhaps observation of the supervisee's work, usually from a distance, and or direct feedback of the supervisee's clinical practice. And we're a big adherent to the importance of feedback. Encouragement, prompting of critical thinking, self-reflection, reflecting on emotional responses, reflecting on personal factors of the supervisee. All of these are critical components of developing clinicians and of clinical practice. Generally in the field, there's been a major shift from an input model to an output model. And this was hearkened by the competencies movement, which has been a significant factor, not simply in psychology, but in medicine, in nursing, in social work, in every mental health discipline. Competencies have been developed, and they serve as a model for incremental, developmentally based training for the respective professions. So the emphasis previously was on input. What particular practices, what particular number of hours or coursework went into the training of a clinician. But with a shift to the output model, the emphasis is on what competencies does the supervisee, the emerging clinician, have at the point of each evaluative moment. So for example, readiness for practicum, readiness for internship, and readiness for independent practice, what specific competencies they can manifest. And this brings us to competency-based clinical supervision, which has strengths in that it is meta-theoretical. So it applies to every theory of psychotherapy, including including psychotherapy-based models, developmental models, process-based models, all of them. Furthermore, it's interpersonal and it's highly experiential, a factor which we're finding to be extremely important in supervision. Competency-based supervision is an explicit orientation to competence. It can be applied across multiple services, across neuropsych assessment, psychological assessment, consultation, in all types of settings, including community mental health, forensics, outpatient, inpatient, and across theoretical orientations. It relies on the supervisee's direct clinical experience with patients or clients and the process of supervision progressing through a monitored competency frame. So competency-based supervision is intentional, systematic, and that's in contrast to many of the psychotherapy-driven models. They may not be as comprehensive in covering all the components of clinical supervision, which are highlighted in this APA supervision guideline.
So, Carol, let me just cut in here very quickly in case people watching this aren't familiar with the models. Originally, supervision theory, to the extent it existed, was really a direct extrapolation of psychotherapy models in which they drew. So you had psychodynamic supervision, client-centered, CBT, and so on. And then, of course, as the field began to mature, we began to develop models more specific to supervision. So I just wanted to highlight that, Carol, before we went.
Thank you. Perfect. Okay, so very important and essential to the process is self-assessment by both the supervisor and the supervisee, and the collaborative effort of the supervisor to give feedback to the supervisee about their self-assessment, because self-assessment is not a strength of any professionals according to the research on this. Feedback, the collaborative development of a training or supervision contract that articulates specific competencies to be attained through direct clinical experience with patients and a means to achieve those. In competency-based supervision, which, as I mentioned, is meta-theoretical, there's an explicit identification of knowledge, skills, and attitudes, and a parsing of those to understand the contributions of each and their interactions. This informs learning strategies and evaluation procedures, and it meets the criterion reference competence standards that are consistent with evidence-based practice, regulations, and the local clinical setting. And that definition is part of the APA guidelines task force definition.
Carol, I'm going to jump in here and play interviewer here for a moment. And would you talk a little bit more about criterion referenced competence? Just
Thank
briefly.
you. Yes. That refers to such documents as the benchmarks competencies, as social work competencies that have been developed by the National Association of Social Workers and the regulatory body of social workers, those types of, and similarly for physicians, they have been elaborately developed. And those serve as markers of readiness for entry into each level of training and readiness to enter the profession. They were developed collaboratively by professionals of all levels within the fields who spent many years developing them, field testing them, and research is emerging that's quite positive about the validity of those, especially within early training in psychology so far, but there's more research ongoing that's supporting them generally. Okay. The next piece then would be the learning cycle. And we feel that this learning cycle derived from Kolb's work in UK is a very important part of what we're discussing today, because first is the performance, which means the supervisee performs the clinical work independently. And this is a very critical part of the learning process. The second part is the supervisor observes via video, one-way mirror, or audio, ideally. It could be through self-report, but we feel very strongly there needs to be some opportunities for observation. And I want to clearly articulate this is not co-therapy. This is simply observing from a distance, hopefully, the clinical work of the supervisee. And through that observation, the supervisor uses the lens of the competencies that the supervisee is developing, as well as the lens of client outcomes and alliance and relationship formation in order to ascertain the most effective ongoing treatment. The next part is the reflective process, and we're finding increasingly that reflection is a little bit of a lost art. And this needs to be remediated because there's so much time pressure for supervisors to get through multiple cases that they're not modeling adequate reflection to step back, think about how the supervisee felt at that moment, what affective changes there were in the patient, what kinds of changes occurred to the supervisee, all kinds of things like that are so critical for development of a supervisee. The next part is feedback and evaluation, and a critical supervisory error is not providing it. It is essential that supervisors monitor, provide constructive feedback that's anchored in the competencies and that provides the next steps of growth for the supervisee as well as the progress of the client. And then there is the planning stage. Planning stage is identifying what the next steps are for treatment, and proceeding with that. Unfortunately, many supervisors jump directly from performance to planning and omit all the other stages. So we feel it's a critical part of the reflective process and the learning cycle to do all of those. Generally, looking at competency-based supervision, it corresponds to the APA supervision guidelines, but I'll just review with you what the particular parts are. One is developing the supervisory relationship and the contract, which grows from that. Second is reviewing the supervisee clinical practice through audio or video review. Next is assessing the relationship ongoing to ensure that if strains and ruptures occur, which they do, that they're addressed. Then we've got increasing multicultural competence or diversity competence of the interaction between among the client, the supervisee therapist, and the supervisor, and thinking about worldviews and conflicting worldviews. Monitoring client outcomes routinely, addressing professionalism of the supervisee, attending to personal factors and reactivity or countertransference, providing assessment, competency-anchored feedback, and evaluation so there are no surprises, ensuring compliance with ethical, legal, regulatory issues and standards, and supporting supervisee self-care. Internationally, there has been a movement toward competency-based supervision. It's been formally adopted by the Australian Psychology Board. It's been formally at least put forth in the guidelines of the American Psychological Association. New Zealand and UK are also manifesting many parts of competency-based supervision. Gonzalez and Calvert have described competency-based supervision as an international movement that's gaining momentum. They feel that also that there's a range of competencies that are enacted independently by supervisees conducting psychotherapy and assessment with clients, and they are required to be intentional, purposeful, and to occur in this independent way. The emphasis on competence and independent practice with clinical supervision is simply burgeoning across disciplines. And they mention not only the ones I mentioned before, but also business is adopting that model. Okay, Rod. Dr. Goodyear.
Okay, so we'd also had several questions posed to us. And one is, what are some of the worldwide trends with respect to supervision models? I think one of those is very much what Carol or Dr. Fellender was just talking about, which is a movement toward a focus on competence and being able to document it. And I think as she talked, it was also clear that the competence model is not just about outcomes and what we're achieving, which is done so nicely, but it really specifies processes for the supervisor. So we're talking about competence for the trainee, but also competence of the supervisor. And the model that she's laid out so nicely speaks to what we should be attending to and how we do it. What are some of the defining and essential characteristics of on-site supervision? Does the approach using primary and delegated supervisors meet the criteria of on-site supervision? So on-site supervision, and please jump in here with me, Carol, that on-site supervision would be the way I would understand it normally, that supervision would be done by someone who's at that site with the supervisee. As a matter of fact, in many states, there's a requirement that the supervisor, in the U.S., that the supervisor be at that site with a good proportion of the time that the supervisee is there. So there's that assumption that they'll be there with them.
But not necessarily, not in the room. Simply
yes, thank you. Not necessarily in the room, but available. So, for example, if there's an emergency, they can find each other. That the supervisor would, of course, know the clientele and all those sorts of things.
The regulation relates more to supervised professional experience rather than practicum training. In practicum training, which isn't regulated, the supervisor doesn't really need to be on site, but needs to be available via some electronic means.
And the assumption, but I think this is the best practice mostly that the supervisors are available. I will say that it's common in training programs to have a site supervisor who's typically the person who's responsible for client welfare and so on, and also then an academic person, a professor at the university who will do secondary supervision. It's probably more technically consultation because it's the site supervisor who has that responsibility for clients. So often in training programs, and there's two supervisors, one who is that site supervisor.
Yes.
And then there's a question about primary and delegated supervisors. And that's often a training model is used as well. So for example, it's common in internship programs for an intern to be learning to supervise. They are delegated. They're supervising, for example, practicum students, but they're also under supervision, so they're delegated in that sense. Would you like to elaborate on delegated, Carol?
Well, delegated, but I think in the last instance, we really call it peer consultation.
Yeah.
Because they don't hold any responsibility. I think the key to supervision is holding that responsibility,
Right.
both legally and generally.
Right.
So that is a common model in order to train supervisees, not simply to do clinical work, but also to become supervisors,
Right.
to get peer consultation experience under the supervision of a licensed professional who holds responsibility for all the cases of the supervisees and the peer consultants.
Mm-hmm. So pros and cons, other questions we have concern pros and cons of different forms of clinical supervision. One was the apprenticeship model, which we've already talked about. Delegated supervision we've just spoken to. So another question then, and the one we're going to end with, concerns implication of attending to clients' interests and feedback in the future development of clinical supervision. And I think this one hits very nicely on the notion of routine outcome monitoring of client progress. So getting direct feedback from clients, and that whole area is just burgeoned. I think Lambert's OQ45 was probably the grand person of all these, but there's so many measures lately that there's a wealth to choose from. And my own take would be that it's important as you look for routine outcome monitoring, which should be done routinely, look for not just measures of client functioning or client dysfunction, but also some of the outcome monitoring measures provide measures of alliance. So, for example, Scott Miller's PCOM system allows monitoring both client functioning and alliance, and there are others like that. Did you have any other thoughts on that, Carol?
No, I think that's an essential component. And we see in the U.S. that about a few years ago, that was not a common practice, but a recent article a few months ago is showing that it's becoming an increasing practice in training clinics in the U.S.
Okay, so those were the questions we had to respond to. Necessarily, this is a short video, and we hope it was useful. Thank you.
Thank you so much.